what are novel therapies that you are most excited about, that you think kind of hold some promise and kind of to be on the lookout for?
Yeah, and I maybe group that into kind of short term and longer term. I think in the short term, I think belzutifan and more broadly HIF-2 alpha inhibition is really promising. It's really a molecularly directed therapy, understanding the biology of kidney cancer and really high HIF-2 alpha signaling that drives a lot of the disease itself, and being able to molecularly target that is fantastic. And I think we've seen, in again, not large randomized phase 3s yet, but in earlier studies, that it's a very well tolerated drug. It has good clinical activity, even in later line settings for patients who are heavily pretreated, and that it's a combinable drug. We saw that with the combination of belzutifan and cabozantinib. So I think all of those things are really promising. It's now entering the realm of phase 3 trials, and we know there's multiple LIGHTSPARK trials. There's belzutifan by itself against severe alignments in the later line setting. There's belzutifan plus lenvatinib against cabozantinib at a still refractory setting. There's belzutifan as part of a pembrolizumab combination in the frontline setting, and even belzutifan in an adjuvant setting in combination with pembrolizumab. And so it's kind of being explored in every potential space within clear cell RCC. And so I think the next couple of years will be really exciting to see where it fits in, what's going to be its best place. But I suspect it's going to have a role in one of those settings, if not more. So I think in the short term, that's the most promising. In the longer term, I still hold out a lot of hope for novel immunotherapies. And in my mind, Checkmate 214 and this idea of checkpoint inhibition really represented an inflection point in how we treat kidney cancer. We had some early evidence from high-dose IL-2 that even metastatic disease is not just treatable, but I think really actually curable, or at least controllable for the long term, but only a very small number of patients. I think with modern checkpoint inhibition and things like nivolumab plus ipilimumab, that number is probably increased. Patients who have really long-term response, I hope even translates into cure. But we need to move from proof of concept to actually having that be the majority of patients. And I just don't think targeted therapies will ultimately get us there. I think they have tremendous value in prolonging life and making people feel better and improving their quality and quantity. But getting to that ultimate goal of long-term control, of really cure, that's going to require an IO-based approach. And whether that's novel immunomodulatory drugs, so new checkpoints and other cytokine-based therapies, or the space of antigen-directed therapies, things like cell therapies, things like vaccine-based approaches, to me, that's going to be the next generation that's going to hopefully not just move the needle and move the median survival, but really lead to long-term survival and cures.
That's excellent. Really exciting to see sort of where the field is going with novel therapies. I think we have a series of VEGF inhibitors and series of, IO agents that are approved, but we really need some new drugs with novel mechanisms of action that can kind of help overcome some of the resistance pathways, enhance our ability to induce deep, durable responses earlier on. And so that's super exciting. Kind of ending here, we highlighted sort of the different kind of therapies, but maybe if you can highlight one or two ongoing clinical trials that are investing various targeted therapies or immunotherapies that you're kind of, looking forward to. Certainly you mentioned the belzutifan everolimus study, but interested to kind of hear if you had to pick, one or two trials, which are the ones you're most excited about.
Yeah, I think it's hard to narrow it down to a couple, and I never want to exclude, because there's a lot of things in a good way that are happening in kidney cancer. I mentioned the belzutifan trials already, so I'll leave those out. And I think probably a couple, one sort of maybe more practical and one forward-looking. The more practical one, which I think is a really good question, is the Pedigree trial. It's a straightforward design, and I think, as a field, myself too, you sort of naively think, okay, 2 drugs is better than 1, 3 drugs are going to be better than 2, but that's not always the case. And that's not, we know we overtreat a lot of patients, we can cause a lot of toxicity, and that toxicity might not only translate into a miserable patient, but an inability to actually effectively receive an effective dose of the therapies too. And so something like Pedigree, an adaptive design that says you're going to get more therapy if you need it, is something that's really appealing to me. And I know that's well on its way to being fully approved. And so getting those results, I think, will be really helpful and informative in the short term. The more sort of, longer term view is the CAR T trials. And I know that we've had one cobalt RCC that's been reported. We've had some initial results from an Allogene trial. These allogeneic stem cell transplants, allogeneic CAR T cell therapies, I think are really, really exciting. And there's a lot to go. What is the right target? How do we improve the fitness of these CAR T cells? How do we, how do we basically optimize these antigen-directed therapies? But at least they open up that space of antigen-directed therapies in kidney cancer. And that once that bucket is open, there's other cell therapies, there's vaccines, there's a whole world that sort of emerges. But those being the proof of concept that antigen-directed therapies can be used in kidney cancer, I think is really exciting. So those are probably the two on the short and the long term that I'd look out for.